Good morning. Here to talk about death, destruction, pestilence, and disasters. Right? Sounds fun. Maybe it's not, but maybe we'll go over some agenda items. We'll talk about what has this been like over the years. You know, what kind of things have we had to deal with as clinical training shops? What about this COVID thing? That's kind of throwing a wrench in everybody's plans. And then what can we do about it? So are there any tools that are out there that are going to make this easier to make it over that hurdle should there be more death, destruction, and pestilence? A little bit more into those. We want to, let's see, what do we want to do? We want to understand the early stages of emergency disaster preparedness. That's important. Probably have to figure out where we're at, where we need to go. Look at some of the disasters that are out there. So maybe there's a hurricane, maybe there's tornadoes, maybe there's global pandemics, lots of stuff that's out there. What has my hospital system done? And how does that tie in with some of the best practices that are now available? Emergency preparedness. Throughout time, past, present, and future. So 1803, we get the first federal government involvement with fires in New Hampshire. Oh my gosh. Told you, death, destruction, pestilence, fires, right? But it's not a cow kicking over and burning down stuff in Chicago. Rolling up in the 1900s, didn't get a lot until the disaster relief programs kicked in around 1950, and then we saw preparedness start to take on earthquakes and hurricanes and how we're going to deal with that. 911 came into effect in '68. Not just a great time to listen to music, but 911 came out, and we also, just in case you didn't know, this year there's a new, I believe it's 988 number for suicide prevention. So just plug for that if you know anybody, if somebody's having a hard time, there's a new national number, I believe it's 988 for suicide prevention. FEMA came out in '79, how to deal with disasters, Homeland Security in 2002. And then there's a lot of directives and emergency preparedness rules that come out until finally Joint Commission, who I imagine like 90% of hospitals are accredited by Joint Commission, they published their emergency management standards. So that's kind of where the rubber meets the road and the story of how we got there. Over the years, so in the 90s, we've got lots of stuff going on. We've got Desert Storm, trying to get people out of Kuwait, if I recall. And the hazard vulnerability assessment, that's this guy over here, came into being, and a lot of your plant engineers may use that. But we're looking for human-related events, ways that we can assess how emergencies are going to impact our ability to provide care. We have to have power, we have to have water. Nowadays, we have to have internet. We may need a clear helicopter pad. There's a lot of things that go into modern healthcare. So how do all of those things line up with our abilities in an emergency situation? Do we have enough ventilators, oxygen, all kinds of fun things? So these things came out around the same time that we had A-10s. A-10s don't fly much anymore. Then 2000, who remembers sitting in a hotel across from the hospital waiting for everything to go down because it was going to be Y2K. Oh my gosh, turn everything off. Remember, turn it off before midnight because the end of the world is upon us. That was pretty tough. And as it turned out, not as big of a problem as we expected. Yes, it's important to have more than 2 characters in your year field for your medical equipment. But outside of that, we were able to get through that pretty well. What nobody really expected was the World Trade Center in New York. And once those came down, once we had all of the patients from those areas that were impacted, they all had to go to hospitals. And they're dealing with, you know, inhalation problems, asbestos problems. Gosh only knows what's in those big buildings when they fall down. So you've got everything from crush victims and fire and burn victims to people who've breathed in just nasty stuff that causes cancer, in fact. So hospitals had to be able to deal with that extreme influx of patients all at once. And they had to farm them out, some even to north New Jersey, to make sure that the hospitals were capable of handling the influx of patients they were seeing. What else is going on? How about 05 to 12? Well, we had Katrina, and you guys might remember New Orleans flooded. They've since built this series of dams and dikes around New Orleans with huge pumps bigger than me. They pump all the water out faster than it falls out of the sky. But at the time, not so much. And they followed this up with a hurricane in Houston. And what they figured they ought to do, instead of building a wall around the town, was they came up with emergency gates that would go up and down in the basement of the hospitals. So if you had, I don't know, MRI, clinical engineering, all those important people in the basement of your hospital, they didn't flood out. So knowing the area you're in, whether it's hurricanes and flooding, maybe it's Tornado Alley, and you have to think about, we're going to get a Category 5 tornado tearing through Kansas and destroying their ER. And that's this guy over here on the end. So we see all kinds of stuff going on with natural disasters, and it's even some man-made disasters. People going out and shooting. There was one in Texas not too long ago with a guy at the top of a hotel. It's not Texas. It was Las Vegas. Person on the top of a hotel just shooting folks listening to a concert. 2018, this one was really neat. There's a YouTube story about it, lasts about 5 minutes. These slides will be available after the show. You're welcome to look. But wildfires in California, right? So wildfires coming up the hill. There's one of those acute access hospitals, only about 50 beds. And they're sitting there and they're going, oh my gosh, the fire's coming, what are we gonna do? And this is a great story about how HTM helped to manage, get the patients into the ambulances and get them out, especially the ones that weren't mobile. How do you get them in, out of a hospital bed into a stretcher and then into an ambulance, get down the road? What about all of your pumps and things that you want to infuse? How do you get your medical library into your machines and then into an ambulance, and then down the road it goes, and it's going to talk to somebody else in some other building somewhere else? So it's really an interesting story about how when your hospital goes away, just goes away, how do you deal with that? And HTM plays a very integral role in how the equipment is able to support the care providers to deliver care even in the process of an emergency egress from the site in the case of a fire. The HTM department did this. They were recognized at one of the trade shows, I want to say the AAMIF Exchange, the following year for just being Johnny on the spot and helping out so much. So this is a really cool story if you get a chance to watch it on YouTube. All right, new challenges. What if we had global pestilence? What if we had this disease that's going to come from bats, maybe, or wherever it comes from? But we're going to have COVID out there, and 2019 it starts. That seems like forever ago, doesn't it? 2019, and then 2020, first cases reported in the United States. There were nursing hospitals in the Pacific Northwest. And then 3 million cases reported by July of 2020 with 40,000 hospitalized. We ended up building emergency wards where we could provide care to all these patients. I'm sure you guys did the same thing, setting up ways to take care of people with respiratory distress. And work conditions for the healthcare providers, right, had to change. So everybody go home. We don't need you here unless we need you here. So maybe we can work from home. Well, how does that impact your IT, right? How does that impact your dialing in and keeping PHI secure? Maybe your RADs have to read, CT images from home. Maybe there's a wildfire coming up the hill for your RAD's house. I did that recently. Restrictions for vendors. Maybe vendors want to come work on stuff, and we're not going to let them because they may not be vaccinated. They may be coming in while we're in the middle of the early stages of the pandemic, and we just don't need one more person walking around the hospital. But how do we have the right vendors coming in to take care of all of our equipment? How do we make sure that we get the suppliers bringing stuff in so that we have enough gloves and masks, soap, food to feed people in the cafeteria? Oxygen bottles, that was a fun one. Who's got enough oxygen at the start of COVID? Not many people. And then setting up, command centers all around the country. We had both locally, your town, maybe state level had some where they tried to coordinate between this hospital and that hospital. Maybe somebody was reaching out to the local colleges and going, hey, we loaned you those vents to teach your respiratory therapy techs like 3 years ago. Can we have those back? And the hospitals are like, or the community college is like, sure, I guess. We're not really teaching a whole lot right now. You can have them back. And they're trying to figure out how do we get the supplies to fix these things and get them up and running again, right? Well, all of that handled both at local, state, and federal level, along with, now let's track it. Whether it's infusion pumps leaving a hospital that's on fire, whether it's, okay, well, respiratory therapy needs 10 respirators at hospital 2, and we're in hospital 3, and we should put them in a truck and we'll ship them over there. Well, tomorrow, maybe we don't need 10 anymore. Maybe we need 9, and we need 1 to go to hospital 7. My organization has 33 hospitals, so just work with me on the numbers. But moving the equipment around to address the patient care needs. And in clinical engineering, I like to say that there's a tripod that makes up modern healthcare, and you've got caregivers, physicians, nurses. You've got patients. They're really important. All falls apart without patients. And you've got the equipment that's used between the two. So the caregiver needs equipment to take care of patients nowadays. So we're all here to support the equipment. So knowing where it is, knowing that we have PMs coming due, how are we tracking that? Knowing we have to stop and look at new guidance released from CMS. Hey, can we skip a PM if it's in use? How do we keep data on all of this? How do we take that data and make it information by interacting with it? How do we make sure that operations can continue? And I think the numbers were 1 in 5 rural hospitals closed. So operations did not always continue. Current state, what do we got going on? Let's see. Lots of fun things going on. So we've got strategies around operations. Your key departments for COVID especially, you need respiratory care. You've got the supply chain. You've got maybe outside organizations that you have to communicate with. So let's stop and let's talk to all of them. Let's make sure that we've got daily communications back and forth. We had them set up both in the morning and the afternoon, just so that we knew, do we have enough protective respiratory equipment? Do we have, for the nurses that are taking care of patients, do we have enough vents available in each facility? How are we doing on oxygen? Do we need to call Praxair or whoever to bring us more oxygen? HTM reports. So it's a pandemic. People are sick. Do we have enough people in the hospitals to provide care? Not only that, but if you're supposed to be 6 foot apart, my folks don't have desks that are 6 feet long. Maybe somebody else's do, but Maybe we should say every other one comes in from 6 to 2, and then we bring in the second shift and we do 2 to 10. And maybe next week we'll swap them. But how to do staffing and make sure we got all the shifts covered, but we have people not in close proximity. How does that work? Ventilator reports. So we had documents that would go out to respiratory care and say, this is where we think they all are. These are the ones we think are busted and ain't gonna get fixed soon. These are the ones we think we have back up to you tomorrow. Admit that many more patients so you can deal with them. Communication buys grace. So if you can communicate all this back out to your caregivers, then all of a sudden they can plan for, we got to defer people down the road. We've got to build a new temporary clinic. We've got to do what to take care of that. And then load in the bids back and forth between different facilities. So we did reach out to local community colleges and bring them back. We did loan vents between facilities. And then we also loaned vents to our competition. So there are 3 main hospital systems where we're at, and we've actually reached out to them, just talked on the phone, said, do you guys have enough vents to take care of your patients? This is bigger than money, this is people's lives. Let's make sure that you're being taken care of. So reaching out and collaborating on that. And then what about surge? How full is your hospital? So if you're at 100% capacity, you've got no more room. There's no more beds. Do you get one of them big tents and put it in the parking lot and try to figure out how IT is going to all go white overnight trying to figure out how to make it secure? Maybe. Do you open up? What's up? I bring it.
Current state for all of your search prep work, I'm assuming, especially given the size of the Intermountain, some equipment that probably moved out of the med centers as some of those searches backed off. I'm curious, maybe it's vents, maybe it's large volume pumps, maybe it's additional physiological monitors. What did you decide to do with that equipment as searches have thankfully have dropped off, but you then look towards preparing for the next search?
We kept all of it in a patient care facility, except for things that could be moved into either an asset disposition facility. We have an entire department for asset disposition. And then we have a central supply center so that instead of hospital A having to order a whole case of gloves and only need 2 boxes, well, let's take care of that. Well, within our central supply center, we can also take some of our extra equipment and have it available, kind of like a loaner pool, to make sure that, especially with our pumps, that we're getting the right number of pumps to the right facility as needed. And we collaborate heavily with our supply folks. Each morning they have a semi truck that goes out to each hospital with boxes of gloves, but also medical equipment in canisters that we have that moves them around the system. So we have that built in as a way to move things from point A to point B. They come to the clinical engineering shop. We make sure that still on the right network, they still function, electrical safety checks, all those kind of things before they go back into patient population, patient production.
CM work happen at the supply center, or would it actually happen at the hospital?
At the hospital. They just and a lot of it's, let's do electrical safety checks, we're moving around, make sure that it talks to the network. Some of the things, hey, function check, it doesn't check out, now it's going to move into that CM status. Let's pull back up a minute and address what's going on. Sometimes it's communicating between technicians, right? So, hey, this is on my list of things that has to be PM'd, but you've got it. Do you want to do the PM or do you want to send it back to me? Well, we still need it. We're having a surge in our town. Your town is 60 miles away, no surge. We're going to keep it, but we'll take care of the PM. So just transfer it to us in our CMMS program. So a lot of that coordination goes back and forth.
So on the ventilator reports, one of the things we identified first how many ventilators we had in our system that could handle an adult baby patient. And all of a sudden, we realized we had like 1,000 beds that could actually do that. The other thing we did in-house website where every shift at every one of the hospitals, the anesthesia or not respiratory therapy went on, and basically, okay, we got bears here, we got these here, we got these here. At one hospital, they went in and put in what was in use.
Yep.
And we already knew which ones were down for repair. So that way we knew how many were available at the site, at every one of our sites. So if we needed to shift some, you could say, oh, well, I don't have any that I can give up. What are you talking about? You only have one ventilated patient, you got 15 ventilators. I mean, you know how possessive some of the directors of interest could be.
Yep.
And so that actually stopped that from occurring. We knew what they had.
Agreed.
Alaris pumps, which was another thing that everybody had to make sure.
Yeah, they do.
We tapped into the Alaris server to see what devices were in use.
Yep.
In use to the Alaris server meant that they was just turned on, but it told us what the brain was and what modules were.
Mhm.
Then we compared it to our inventory, and all of a sudden we realized, according to the inventory, we were only running like 30 to 35% of our pumps were actually in use, but everybody was telling us we need to rent more.
Yep.
And
Same story.
that was, by us being able to do that, we didn't have to go out. I mean, we did go out and buy some pumps, go out and rent some pumps. In a 25 hospital system, acquiring another 500 pumps was nothing compared to the 5,400 we already had in stock. That was just the brains. We had 14,000 modules.
Yep.
But, I mean, knowing what you got and where you got it was an important thing, in our managing that type of situation.
Yep. Very much agree. We've since leveraged that, knowing what you've got and where you've got it, and rental costs, to saying, we'd like to stop renting these pumps and instead just know where they're at. So give us that bucket of money and we'll go buy an RTLS system. So now we'll know where everything is and we can tell you, no, Mrs. Jones, it's actually in this room, and the only thing in this room is your desk. So can we check in your desk? Do you have any pump modules in there? Can I have them back, please?
One patient faster than normal because another patient.
I don't know that we had a special program that was better than anybody else's. It was just, let's make sure that we clean and sanitize everything. And then we have enough consumables to make sure that's done in a safe fashion.
At the time of COVID, I was out here in the West Coast, and I was talking to like 4 or 5 of my contacts on the East Coast, managers in electrical engineering, to find out what is it that you're seeing with your patients out there.
Mm-hmm.
And my hospital, I was talking to John Hopkins, I was talking with UHS, I was talking with Christiana Care, all of them. I mean, I was talking, so one of the UHS is based out of like Philadelphia, but I was talking to the HTM people. Said, what are they? Oh, well, not only are we using the ventilators, but we're having a hard time trying to find the paralytic to give to the patient. So I'm talking to my team out in California, saying, where are we for paralytic? What does that have to do with medical repair? It has nothing to do with medical repair, but if we put a lot of people on ventilators, the East Coast is saying they're having a hard time getting them paralytic.
Yep.
And so by being able to find out what other people were running into shortages on the East Coast, I was actually able to prepare my team. It's like I had one question that I asked on day one and never got an answer on it. You want me to get 1,000 monitors? What parameters do you want on those monitors? What parameters? What do you want? Well, typical ICU parameters, they say.
Yeah.
Oh, so you want invasive blood pressures? And nobody seemed to know what I was talking about. It's like, having, an NIVP versus an invasive blood pressure, big difference there.
Current state. Maybe some more. So daily staff assessments, let's make sure that we know what's going on with everybody's families. Our biggest department at Intermountain is labor and delivery. Maybe some other hospital systems, it's cardiovascular or radiation oncology, but ours is L&D. And And keeping an eye on what's going on with people's families is really important to our caregivers. It's helped us sidestep some of the things when people are suffering now with the burnout and the engagement. But if you've got a sick child at home, you're going to want to stay home and take care of them. So there's people that are no longer just calling out because they're sick, but it's family health. What about all of the data that goes with that, from waivers that CMS has in place for when you have to do your preventative maintenance? Are there any equipment shortages in your state or in your 7 states, or things that you need to share, including staff? If you've got, we had a hospital that lost the entire shop. Oh well, no shop for you. Back of the line. So bringing folks in that are willing to come and give a hand. Hey, overtime's approved. We need somebody to come and at least handle some of this stuff. Sharing staff, and then search for preparation, 3D printing of some of the tubing parts. You could scan them in. Sometimes with the CT, we scan some things that high a level, and then 3D printing worked. Or looking at can you put 2 patients on 1 vent? What if they have different volumes? How do you get the pressures right between them? Some of those kind of things had to be dealt with, but we did. And then looking at repurposing some areas. So one of our 4 biggest medical centers, we ended up taking almost half of one of our L&D wards and turning into a COVID care area. So temporary walls, change the ventilation around, all kinds of fun stuff, but repurposing areas to make sure that they were appropriate for the patient population that we were seeing. Yes.
But how was that collaboration? Because I can imagine with my facility, everybody has their own idea of how things should run, but how did that, who spearheaded that collaboration and how did that work?
So our HTM department is there to fix the equipment to support the caregivers. We actually turned that over to respiratory therapy and said, you guys are the experts on respiratory therapy. We can tell you everything about the machine and its capabilities, design a valve that you can adjust pressures, whatever is needed. But we're going to leave that to the licensed care provider to actually issue that episode of patient care. Gosh, what are we talking about? Let's see. It's been a minute since I saw these slides. Temperature checks from everybody. Is anybody still doing that? Still have the signs up by the door that say you are, even though you're not? Temperature checks for everybody. Drive-through testing sites. I haven't seen one of those in a minute, although I did see one last week for a flu shot. Got my flu shot. Ventilator shortages, and what are we going to do about it? Do we bring in ventilators from other areas? Are we setting up tents in parking lots and creating temporary isolation areas, temporary places where you can handle people? What about disinfection? Can't get enough N95s. Can we disinfect the ones we have and reuse them? Yep, that's where we did that. PAPRs. Oh my gosh, we need those personal air respirators and make sure that they're working. We even had about a half a year where that was on every morning call. How many PAPRs are available? How many are in use? And tracked that diligently day by day. Parts availability. I think everybody probably saw some of this, but with the FDA coming out and saying, hey, we need to make sure all this is done the right way. Can 3D printing work? Nope. Can it work for the next 6 months? There are rapid approvals. We saw different medicines getting approved rapidly. As well as, what do you do if the manufacturer can't get there? Because they don't have the staff. They don't have the staff who is able to come on site for whatever reason. Maybe you're quarantined. And net new devices into your facility. How do we make sure that these new makes and models are evaluated, tested, put into production appropriately. I mean, Ford was manufacturing ventilators for a while there, and well, what does that look like? What does the PM look like on a Ford ventilator? You get the blue oval. Is it found on the road dead after it doesn't work? Bed shortages, all kinds of fun things. So stopping to look at what care was like during the height of COVID, well, it pointed us towards what worked really well, what we want to duplicate, what maybe didn't work quite so well. So here we are in the business of healthcare technology management. We need to keep it running. So what does that look like? Well, AAMI has a document out where they say, you know, you ought to have an emergency plan. Maybe we can help you put that together. And there are other emergency management updates that came out at the same time. So we want to make sure that we're assessing risk the appropriate way. Are we able to provide care for all of those patients? Do we know who to call, what to call? It's not Ghostbusters. So if we're having a problem and there's an incident on our site, how do we get everybody involved? How do we make sure that everybody who needs to know is informed? Do your CE1s, when they're on call, know where the incident command center is? Do they know what the playbook is for loss of power? How clinical engineering ties into that? Do they know how it ties in for everything else? And then recovery and record keeping. How do we deal with this afterwards? How do we say, okay, these are some of our lessons learned. These are the things that we put off all the PMs on. Let's now go back and catch those. Software, all kinds of those expenses that came up because we've now been, you know, just making it work for a year and a half. How do we come back and make that better? So there's a new document out from AAMI just this last year that says we'd like to help you assess the level of competency that you have in your department, help you come up with some things that maybe you didn't think about. So how would you participate in a loss of network services? How would you call the CISO? Well, what's their phone number? What's their email? So there's documents now that if you have your local site managers fill out, CE1's on call at 3 in the morning, they can actually pull out your playbook. They can say, hey, this is what we need to do. So what kind of forms are there in all of this? You got critical suppliers, where all your staff are, how to damage, assess, business recovery expenses, post-emergency tasks. And all of these things are well, maybe they're common sense and intuitive. You sit down and you think about it for a year and write a standard, but you don't have to. This has already been done. So now it's just a matter of stepping through a form and documenting what your practices really are, and then making that available to your caregivers, to your team members, so that 3 in the morning when you're in Napa Valley at one of these shows, you don't have someone calling you on the phone saying, we lost the network, what do we do? Well, patient monitor needs to be up. Go to the incident center, pull out the playbook, start on page 1. What's an incident center? Golly, go to the basement, walk around the corner, stay on the phone, I'll guide you there. But to make sure that each member of your team knows what's going on, knows who to contact, how to contact them, when to contact them, that we can contact each other. Bob, I really don't know how to fix this. Talk me through it. Really goes a long way. What else we got in here? So the TMC had a subcommittee that came out and did this assessment, and I think we're going to talk about it a little bit. If we say, here we go, introduction, understanding all of it. Federal, state, regional facilities response plans follow the NIMS model That's in the hospital incident command system, which you guys probably all have in your basements next to clinical engineering and in the lab and the morgue and all those fun places, MRI. How do you say who's in charge? Who's the person who can say, yep, do this, don't do that? What about risk assessments so that you know you've got enough diesel in your generator to last for 96 hours? Or does it have an oil leak? You gotta shut it down and bring in an emergency generator just in case. Is HTM participating in drills? I mean, we do power runs every month, right? When they swap over and swap back, does anybody walk around and talk to, I don't know, CT? CTs hate being bloop on power. So how much is HTM participating in some of these drills? Are there IT drills? You know, so people sit down and have a tabletop exercise and say, let's imagine that North Korea decides to target our facility and they're coming in and they're going to take down our network and then, what do we do? Well, common spirit's going through that right now. It happens. What do we do? And if CE has been part of some of those tabletop exercises, then you can speak to that. Your team can speak to that. And then it's not pulling your hair out and bending the wheel at the last moment while you're in that high stress situation. Now you're just going through a form and you're going, all right, step one, call IT. Yep. Step two, let's go and make sure that the communication is happening between nursing and radiology and OR and all that's coming across like it's supposed to. So all of those are now pieces of a set protocol that you do in your drill, that you do tabletop exercises, as opposed to just, well, CE doesn't really play a part in that, because you do. Facilities has to know that. IT has to know that. Your hospital administrator has to know that. Risk has to know that. So going through this document that was created, stop and think about your hospital. How many beds do you have? How many of them do you really use, though? Maybe you don't use all of them. You got 500 beds, but you only use 350 of them. Are there other offsites that you support? Maybe there's an ambulatory surgical center. Is that going to be really important during an emergency? Darn well might. So what other things are important to assessing your facility? Where do you live? Are you in the middle of a metropolitan area, in the middle of nowhere, only 30 beds? Is there somebody you can call for help? What about staffing?
Years ago, semi-private rooms.
Yep.
And the insurance groups stopped paying for in-house surgery and moved towards the outpatient surgery. They took the beds out of the rooms and made them private rooms. Hospitals never really lost. I mean, on paper, it went from a 100-bed hospital to a 50-bed hospital. But those beds, in most places, didn't get lost or gotten rid of. They got shoved in the storage room or someplace else. And so all of a sudden, I mean, during COVID, you saw private rooms now going back to being semi-private rooms.
Yep.
So that you could handle the overflow. Yep. And they were getting exemptions to their licenses for being a 50-bed hospital to going back to being a 100-bed hospital.
Yep.
So I mean, that's something that people don't keep in the back of their mind. It's like, because a lot of our nurses today, I'm going to say, are new, and so they weren't around, 8-10 years ago when we had all these semi-private rooms, and now they're private rooms. So I mean, it's sometimes it's nice to have some of the ancient geriatrics around to know what it used to be.
How did we used to do this and why? Been thinking about what goes into keeping you prepared. Well, you have to have your incident command center. Where do you keep all the documents? Where's your playbook? But HTM has to take part in this. You have to make sure that you agree to help where needed, that you've got your vendors agree to come in and help. They're going to have staff that are available. And and that you participate on all of the appropriate committees and drills and don't get left out. So when there's a loss in network, you have no idea what to do, or your people have no idea what to do, and they call you at 3 in the morning. Thinking a little bit more about that, shouldn't just have a medical equipment management plan, but there should be an emergency management plan with all of these components. How does your HTM department fit into it? And what if that's just not enough space? What if you have to put up tents in the parking lot? What if you need to go back to double occupancy rooms? What if you need to move patients to another site? How does all that work? How do you deal with the equipment? How do you support caregivers providing episodes of patient care? And then, let's see, clinical operations. This is lots of fun. So what about isolation beds? You have people with respiratory distress, all kinds of fun things coming out of their body. Maybe we need to have them in negative airflow bed. What happens if there's a radiation incident? Maybe there's a dirty bomb. Maybe that tea kettle that went off at the end of the Boston Marathon wasn't just a tea kettle full of BBs, but what if it was a dirty bomb? Radiation exposure can be a big thing. Who's your RSO? How do you make sure that we're addressing that, treating those patients? Pharmacy lab, sterilizers, you gotta to be able to provide the appropriate amount of service to take care of your patient population. So evaluating all of those things, these are just boxes on this form you fill out, and it walks you through assessing your current level of readiness. Logistics and facilities. Again, we're thinking about PPE. Do we have enough masks? Gosh, you'd think so at this point, right? But what about consumables? What if there's a bag you put over a C-arm so that when it goes into the OR, it doesn't get all contaminated with blood? Do we have enough of those sleeves that go over the bottom of a C-arm? What about medical gases and ventilation? Have you got enough, not just oxygen for your patients, what about calibration gases needed for anesthesia cards, right? How's all that going to come together? It's the logistics piece of it. And then let's get the word out. So how do we tell people that don't belong in your building? Well, that don't get paid to be in your building. How do we tell them? Guys, we really love that you're volunteers, but we might need you to go home today. How do you tell your staff? There's 2 feet of snow coming. Governor's going to declare a state of emergency, the state's closed. You should still be able to drive to work and help. So how do you tell your staff about states of emergency and communicate that out? Who's on your volunteer list? Who's on your on-call list? What about media relations? How do you tell Channel 5 News what you guys are doing, right? To making sure that all happens. Moving on, we've got the need to train everybody to this, to make sure that we're participating in those exercises, that we want to improve all of the way we perform. Quality is one of those words that keeps getting tossed around. I like to define quality as you say what you do and you do what you say. So if you do that accurately, that's high quality. And then after action reports. What did you do? Who are you telling about it? How are you making sure that you're held accountable for what's going on? If you come to this conference, do you tell your team what you learned here? What's the one thing you brought back that made it worth coming to the conference? After action reports are pretty cool. And then let's try and improve. How do we do that continuous improvement? The last summer, the Joint Commission added continuous improvement as a requirement in your EPs. So this is one of those things that can check that box for continuous improvement for the Joint Commission. There are some appendixes in the forms that Amy developed, an example letter that you can provide to your employees so they can carry it in their car. So when they're driving in that 2-foot snowstorm and the highway patrol stops them and says, what the heck are you doing out and about? They can show their badge, they can provide the letter, and then go on into work. Sample HTM business continuity plan, and some things you should think about schedule maintenance. Ta-da! You listened to me for this long, you didn't die. Wasn't death, destruction, and pestilence. Questions, comments, concerns?